told me you had a consult with him. We had been told about him. I missed last year, and so I started emailing him, and he said yes, he could do this. Then I saw the title, and I was so pleased, because we hear from all of you and everybody that's in the office that they go online and they see all these things, and they're going to try all these things. Our children send us all this stuff online. And I loved what you have to say to them, so thank you so much.
Well, it is a pleasure to be here again. So I had a great stay last year in the beautiful Gulf Coast of Florida, and my wife is here. We're looking forward to another 3 weeks here. And so this is an interesting sojourn for me, and I'm more than happy to talk to you folks. So the title here is really based upon one recognition that I think is pretty important. There's a lot of misinformation on the internet and in newspapers and magazines. Half of it is untrue. The question is which half? And that's always a challenge on the internet, but this is, I think, especially challenging when you're reading the Parkinson's disease literature that's on the internet. Revenue streams, it's really, medicine is a lot like politics. You know, revenue streams drive the discussion quite often. It shouldn't in the world of medicine, but in fact it does in the world of medicine. And so drugs that are highly priced are more likely to get publicity. Drugs like carbidopa, levodopa get about zero publicity because there are no revenue streams that drive the discussion. So before we talk about, the title is Debunking 10 Myths, I'm going to give you some background, because probably not everybody in the audience is quite totally up to speed with some of the nomenclature, some of the different terms, the anatomy, and so I think it's worthwhile going over a few things. So Parkinson's disease is a neurodegenerative disorder. So what are those? Well, it's different than strokes and brain bleeds and multiple sclerosis, where there are structural lesions in the brain. There are structural lesions in the brain of people with Parkinson's disease, but they're all microscopic. The structural lesions are the so-called Lewy bodies, which are microscopic things that you see, obviously, under the microscope. MRI brain scans in people with Parkinson's disease are essentially normal. Neurodegenerative diseases typically start in middle age and beyond, and you recognize some of the names. Alzheimer's disease, ALS, which is Lou Gehrig's disease, and a number of things that have funny names. These are all brain disorders where there is early aging of brain systems, but it's not uniform. The whole brain doesn't age, the whole brain doesn't degenerate, but it's certain systems. So if you know about Lou Gehrig's disease, it's a terrible disorder, and people die within about 3 years of seeing him in the clinic. And the reason for that is about 99% of the brain is normal, but what isn't normal is the final common pathway, where the motor system projects down to the breathing muscles and down to the swallowing muscles, and typically it's you can't breathe and you can't swallow, and that would be the fundamental problem of people that have ALS. But the rest of the brain really, it's not 100% true, but it's about 90% true. The rest of the brain is really uninvolved. Parkinson's disease, it's a different set of neurons that are involved. And so I've got a couple of names on the screen here. I wonder if we can turn down the lights a little bit. You think that's doable? Because it's pretty hard to see that. So the systems that degenerate in Parkinson's disease early on, substantia nigra, which projects to the striatum. So those are two terms. If you don't know those, it's worthwhile learning those and recognizing those, because that's really a substrate for treatment. So these are actual brain slices of the midbrain in people that have Parkinson's disease and a normal person. So up top here, that's a midbrain from somebody that died, did not have Parkinson's disease. Just below is a midbrain of somebody that died and did have Parkinson's disease. And there's a distinctive difference, substantia nigra, so black substance. And that's what degenerates in Parkinson's disease as substrate for the neurologic problems. The shuffling gait, slowness of movement, loss of arm swing, shortened stride length, etc., etc. There are neurons, your brain cells, that are fundamental for modulating movement, modulating the speed and amplitude and the likelihood of movement. So I also mentioned the second term, striatum. Well, the striatum is shown here by these two arrows. If you can get the lights down even more, that would be fabulous. And if you can't, we'll work with what we've got here. Substantia nigra. Here's the spinal cord. This is an actual human brain section. Top of the head is up there, right, left. This is the substantia nigra, black substance. And the striatum is really two nuclei, caudate and putamen. So there's the caudate, there's the putamen. Those together make up the striatum. So that's a worthwhile term to know because that's where the substantia nigra projects. So what you need to know is that brain cells, there are 100 billion neurons, 100 billion with a B. 100 billion neurons, and this is a phototypic neuron. So there's a cell body, like we all saw in high school and college biology with a nucleus, but neurons have long wire-like processes that come out of that. And so when the cell body is activated because something else, projected to it and activated it, then the conduction is done this long wire-like process to the very end. At the very end are these synaptic terminals, and there's a chemical that is released there, and that activates or inhibits the next neuron in the sequence. So this is a pretty amazing kind of thing. So you've got 100 billion neurons that are sort of shaped like this. Now, because of the constraints of the picture, it just shows a very short axon. But there's some axons that literally are this long. For example, the axons that would go from, I mentioned in ALS, the motor cortex all the way down to, for example, your leg. Those might be that long, but they project onto the spinal cord. So the critical factor in Parkinson's disease that produces the slowness of movement, the stiffness, loss of facial animation, is the loss of the substantia nigra, and especially then the projection to the striatum, where the neurotransmitter dopamine is released. So that is a signaling chemical. So neurotransmitters are signaling chemicals. There are very few dopaminergic neurons in the brain. It's far less than 1%, but they're critically localized to an area that, again, it modulates the speed, amplitude, and likelihood of movements. And if you have no dopamine, you can't really activate much at all. If you have too much dopamine, you move too much. So there's a certain amount of dopamine that's necessary to modulate movement. And in Parkinson's disease, an important discovery back in the 1960s was that dopamine levels are low in the brains of people that have Parkinson's disease. So here's the simple construct. Substantia nigra, and again, spinal cord, top of the head, right, left. Here is the substantia nigra. There's a cell body located here, a lot of cell bodies, and they project with these long axons all the way to the striatum. This is the putamen, that's the caudate, projects to both of those, and that signals something that modulates movement. So people that have Parkinson's disease have lost this system to different extents. So dopamine is the substrate that we are trying to replenish with our treatment. No matter what the treatment is, pretty much all of this goes through doing something favorable to dopamine neurotransmission. Now, dopamine isn't the whole story, and I'm going to digress for just a minute and telling you a little bit more about the rest of the story. But for the most part, when we're talking about treating Parkinson's disease, we're talking about treating the dopamine deficiency state. And we can do that to variable degrees, and some of them are really quite effective. So this is the digression. Let me see here, I think I need to go. This is the slide that I wanted to show you. So this is the Brock staging scheme. This is a neuroanatomical staging scheme. So people, there are different staging schemes. The more common one is Hone and Yar. And that was concocted in the 1960s and reflected the lack of any kind of useful therapy for people with Parkinson's disease. So the fifth of the 5 stages was you're pretty much bedbound, and stage 4 was you needed gait aids and so on. So a lot of people go through their entire lives and they're still walking. and with Parkinson's disease, given the fact that modern medications can really do a very good job in replenishing the dopamine in the brain. But Heiko Brack is a neuroanatomist in Frankfurt, Germany, and he looked at a lot of brains of people with various stages of Parkinson's disease, and he put together the staging scheme that turns out has very good validity for Parkinson's disease. And what he concluded, based upon looking at these people with all the stages of Parkinson's disease, is that actually Parkinson's disease starts years, decades sometimes, before the motor symptoms of Parkinson's disease. So for example, people that are constipated have a substantially increased likelihood of later getting Parkinson's disease if you're constipated in midlife. A lot of people are constipated, so it doesn't mean if you're constipated you're going to get Parkinson's disease, but it's a probabilistic kind of thing. It increases the odds. People that act out their dreams, that's called REM sleep behavior disorder, REM for rapid eye movement. That's the dreaming state of sleep. Normal folks are limp when they're dreaming. People that have REM sleep behavior disorder aren't limp because the switch in the brainstem isn't thrown, and that's what Heiko Brack said. The problem starts in the brainstem and also the autonomic nervous system that controls the bowels. People that act out their dreams in midlife have a significantly increased risk of coming down with Parkinson's disease later in life. This is the olfactory bulb, which never gets much publicity, but in Parkinson's disease it does, because loss of the sense of smell is something that sometimes precedes Parkinson's disease motor symptoms. So those are the earliest stages. You probably can't see this very well, but I'm outlining the midbrain. This is where the substantia nigra neurons are located. So according to Brack's staging scheme, this is a very, very slow ascending process. So for example, in Rochester, Minnesota, where we have a captive audience, you know, people who live in Rochester, Minnesota, they never leave. So it's sort of the opposite of Hotel California, where you don't want to leave. In Minnesota, people will like it there and they stay there. But they have to like snow though, and 0 degrees temperature kinds of things. But nonetheless, we've got a pretty much captive audience in Olmsted County, Minnesota. And it turns out that we looked at a number of people that had REM sleep behavior disorder and Parkinson's disease, and there were about 20 of these folks that had REM sleep behavior disorder starting more than 20 years before they developed Parkinson's disease. In fact, I saw 2 couples that were in their 70s, and the wife each said the same thing. They said, you know, Charlie did this on our wedding night. You know, it was punching and kicking and stuff like that. So you can see here that Parkinson's disease isn't just when you first get a tremor or your gait is shuffling or you stoop. Parkinson's disease can start many years before. So it's a very slow process where it slowly goes through the systems and to variable degrees. Some people never get much further, but sometimes this whole ascending process, this is the Lewy neurodegenerative process. Remember I said Lewy bodies are things you see under the microscope? Well, these Lewy kinds of processes, alpha-synuclein is maybe the bad actor protein that you see under the microscope. This is a very, 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 very slow ascending process. And when you get us up to the cortex up here, that's the thinking area. And so that's the area where you may become demented, lose cognitive skills. So it's a very drawn-out process. And people that have Parkinson's disease, typically, not always, but typically they go many, many years before dementia starts to become an issue. So going back to dopamine now, so the fundamental treatment for Parkinson's disease is restoring brain dopamine. So as I mentioned, dopamine levels are low in the brains of people with Parkinson's disease. It's almost by definition. Substantia nigra degenerates in people with Parkinson's disease. You really can't see that on an MRI brain scan, and certainly not on a CT scan, but that is in fact what is happening. So the treatment is levodopa. Levodopa. Now you might say, well, why don't we give people dopamine? Well, there are 2 reasons for that. And one is, the primary one is that dopamine doesn't cross the blood-brain barrier. And the other one is that if we give people dopamine, not levodopa, but dopamine, it crosses in one tiny area in the brainstem that's the nausea and vomiting center. So dopamine does no good and makes people vomit. But it was discovered in the 1960s that you can replenish brain dopamine by giving the immediate precursor. The precursor means chemically it's one step removed from dopamine. That's levodopa. It's an amino acid that we all have in our bodies. We have a bunch of different amino acids, and this is one of those, and the brain is capable of easily transforming levodopa to dopamine. So that was a huge discovery in the 1960s. The FDA approved levodopa as treatment for Parkinson's disease in 1969, and it turned out to be a wonderful treatment, except it took a zillion milligrams of levodopa to do any good. And number two, people vomited with that. Pretty common, nausea and vomiting. So scientists get a lot of credit for this. I mean, they recognized early on the problem was that the dopamine being generated outside the brain, couldn't get into the brain. In other words, if you had premature conversion of levodopa to dopamine in the circulation, you've taken that molecule of levodopa out of the, it won't do any good because it can't get into the brain, but it gets into the nausea and vomiting center where you have a porous blood-brain barrier. So scientists recognized that what they needed to do was to prevent the premature conversion of levodopa to dopamine in the bloodstream, in the circulation. So they invented a couple of molecules. In Europe it's benzyricide, in the US it's carbidopa. So carbidopa can't get into the brain, and it does one thing. It blocks the enzyme that converts levodopa to dopamine. So it does that in the circulation. So basically, it protects levodopa, and that turned out to be a godsend for this nausea and vomiting problem where people can now take levodopa with the carbidopa, and it's a very tiny percentage of people that have trouble with nausea, at least in my clinic, and I think that's generally true. So you all probably know carbidopa, levodopa, but there are different names for it, and if you have a physician that says levodopa treatment, or cinnamon treatment, or Ahldopa treatment, we're all talking about the same thing. So carbidopa, levodopa is sometimes abbreviated to Ahldopa or levodopa. Cinnamon is a brand name. When Merck, who had the rights to this, put it on the market, they cleverly used Latin, cinna, without emesis, without vomiting. So that was a brand name for carbidopa, levodopa. And sometimes I will use that too. Just it's a lot easier saying cinnamon than carbidopa, levodopa. And then I mentioned here, I put in parentheses, Rytary. That's a form of carbidopa, levodopa, but it's not something that has any utility early on. And the treatment of this is for people that have short duration levodopa responses, and this adds 1 hour onto the levodopa response in people that have that problem. Not a problem early on in the course of Parkinson's disease treatment. All right, so now we're getting to the 10 myths portion of this talk. So myth number one, and I'll read this. Levodopa, myth number one, levodopa stops working after a few years. So that used to be prominently placed in the introduction of a lot of magazine and newspaper articles, and you'd think that, boy, I only have 2 years of levodopa treatment, then it's going to stop working. Well, that's dead wrong. So people that take carbidopa, levodopa, and I've been practicing long enough. I started on staff at Mayo in 1981, so I'm still seeing people that I saw 20 and 30 years ago, and I can tell you for a fact it doesn't stop working, but because of the natural history of Parkinson's disease, it's like aging. Every day, doggone it, we're a year older. Every year we're a year older, and every decade you really know you're a year older if you compare to the previous 10 years. I'm testimony to that. I'm getting a knee replaced in a couple of months. And so that's what happens with the natural aging process. Well, the same ball of wax for Parkinson's disease. Things aren't quite as simply a dopamine deficiency state after a number of years. It doesn't mean it stops working, but I usually tell people when we're initiating carbidopa, levodopa, I'm expecting you, the person with Parkinson's disease, to improve by 70 to 80%. Now that won't be the case after 15 or 20 years of Parkinson's disease. It doesn't stop working, but the improvement, if we look at not treating and treating, the improvement would be more in the order of maybe 50%. And then once you're over age 80, that's sort of where if you're lucky enough to live that long. A lot of us have good lives after age 80. But in point of fact, if you think about all of your friends who are over age 80, they're not quite as steady as they were before. They're a little bit unbalanced. Maybe they're a little stooped, and they don't have Parkinson's disease, but they're stooped. They move a little slowly. Sometimes they even shuffle just due to aging. And so the aging process also, after age 80, gets superimposed on Parkinson's disease. So that also translates into levodopa doesn't work as well once you're over the age of 80. Now, is it precisely 80? No, that's sort of when I see folks in the clinic, you know, if they're over age 80 and I'm diagnosing Parkinson's disease, and if I want to treat it, I don't tell them I expect you to improve 78%. I tell them I expect you to improve about 50%, because some of their motor symptoms that I'm seeing, I'm thinking probably they're due to aging. And those are obviously ballpark figures, but that's just what spending a lot of time in the clinic has taught me. Myth number 2, almost everyone develops disabling dyskinesias on levodopa. So dyskinesias are those wiggly movements. Last year, I think I mentioned Michael J. Fox was in The Good Wife. So if you remember nothing about what I said last year, you might remember that. And there were times he was really great, and there are other times he was like this. And that's from too good a levodopa effect. That's what dyskinesias are. They're wiggly, they're motor wiggly movements. A lot of times people feel pretty good with those. They're not painful. If you have painful kinds of cramping of the toes, or a foot is turning in, or your calf is kind of cramped up, that's not a levodopa overdose effect. That is a levodopa underdose effect. Okay, so we're going to see a gentleman who's, first thing in the morning, taking no levodopa overnight. So he's had this for a long time, so his responses are not nice and stable. So he has to take this every so many hours. So this is a resting tremor. It's a rhythmic movement. That's how you define tremor. It's a sine wave. So he's trying to do pronation, supination with his right hand. Now he's doing it with his left hand. So he is untreated right now. Now he's treated. Look at that right lower extremity. His right lower extremity is kind of wiggly like that. That's dyskinesias. So the rest of him is pretty good. Now that pronation, supination is really pretty good again, but that right leg has a mind of its own, and it's doing that. And we're going to, in just a second here, see his right arm go behind his back. That's also common in people that have dyskinesias. But that foot is sort of, it's not a pattern movement, it's kind of chaotic movement. Now compare that to a tremor, because people with Parkinson's disease can have a tremor of the leg, but that's a rhythmic movement. It's a sine wave, it's a pendulum swing. See that arm go back like that? That's also a dyskinetic movement as well too. But the leg works well. If you ask him how he feels, he'll tell you, well, I feel pretty good right now. In fact, people with dyskinesias, they usually feel the best when they have dyskinesias. Now, it's a problem when you've got Michael J. Fox wiggly movements like this. That's a problem. If somebody has foot movements like that, if you ask them if that bothers you, they may say, well, you know, if you're a public speaker, let's say, obviously that might bother. But most folks would say, well, it's not a real big deal. So what's the probability of getting dyskinesias? So this goes back to that old statement that, you know, almost everybody gets dyskinesias. Well, this is Ahlskog County, Minnesota data here. So these are folks that took levodopa for 5 years, and we looked at the age that they started the levodopa. And it turns out, you know, actually we didn't have anybody that got Parkinson's disease in the Michael J. Fox age in this incident cohort from Ahlskog County, Minnesota. In Great Britain, they tabulated a group of young people with Parkinson's disease, young onset, as they defined it as onset before age 40, and by 5 years of levodopa, 95% had dyskinesias. Here, if it's in the 40s and 60s, about half had dyskinesias after 5 years of levodopa. But after age 70, people that started Parkinson's disease and took it for 5 years, 16% had dyskinesias. That means that the remainder didn't have dyskinesias after 5 years of levodopa treatment. So it's very much an age-related kind of thing. These are all probabilities, but that's the way physicians think about things in terms of probabilities. More dyskinesia myths here. Myth number 3, dyskinesias are worse than Parkinsonism. Well, it turns out, and this is something that is often overlooked, but if you're seeing me in the office today, if I'm back in beautiful Rochester, Minnesota, and you're seeing me in the office, and you've got an arm that's doing this, and you're asking me, well, how much do I need to give you to get rid of that? And I'll say, well, how much do you got? Well, I got 10 bucks in my pocket. Okay, here's the answer. Your next dose, you reduce that by a little bit. It's driven by your last dose of levodopa. So people that have dyskinesias, it's the dose you just took. It has nothing to do with the total daily dose. It sort of does, but it really doesn't. It's the dose you just took. So if somebody took, let's say, 2 of those carbidopa, levodopa tablets, and they really had troublesome dyskinesias, you'd say, okay, let the effect wear off, which typically takes, 3 to 4 hours. Okay, next dose, now you got a clean slate, levodopa effect is come and gone. This time take 1.5 tablets of carbidopa, levodopa. And typically just a small reduction like that is effective. If it isn't, you can go down to 1 tablet. You can always get rid of the dyskinesias altogether by dose reductions. So again, important to know it has nothing to do with the total daily dose, which is often a common misconception. So here's more data from Olmsted County, Minnesota, the county where the Mayo Clinic is located. So this is now 10 years of levodopa, and the probability that people had dyskinesias that were sufficient to require their levodopa dose needed to be adjusted. Well, it turns out the majority did not. So it means that most people in our cohort really didn't need to have anything done because they either had dyskinesias that were so trivial or no dyskinesias. 43% had to have their levodopa adjusted. So then you might say, well, that's fine, but what happened when you adjusted it? How many had problems? Well, it turns out that after 10 years of levodopa, only 12% had problems where they really couldn't satisfactorily eradicate the dyskinesias. Then you might say, well, you just say you can always get rid of them. Yes, well, here's the problem with these 12% of people in 10 years of levodopa. They lower the dose, dyskinesias go away, but they say, boy, I'm not walking as well. And then you go back to the dose you just took, now you have dyskinesias. So that's the problem people run into. But I can assure you, you can always get rid of dyskinesias. But when you go online and read about dyskinesias, you might think, boy, this is really a terrible problem. But in my clinic, it's not a problem per se. It's just if you're one of those few people where you've got a very narrow therapeutic window. The sweet spot is you're either overdosed or underdosed. And I think that's probably, when Michael J. Fox was on The Good Wife, I suspect that was his problem too. He was an actor, needed to be on, and needing to be on, meaning that he probably tended to overdose a little bit, and then he would get dyskinesias. Myth number 4. This is still common. I probably get asked about, I'm in the clinic all day, every day, and I'm guessing that probably every week I get asked this, probably at least 3-4 times a week. It used to be, this would come up pretty much with every patient. Well, I want to save my levodopa for later. Are you sure I should be taking it right now? Well, that was a very common statement you'd read online, and I would hear it from patients who said their neurologist told them to do this. Well, it's bad enough you have Parkinson's disease, and here we've got a fabulous drug for Parkinson's disease, I think. I mean, it's not the cure, but it really helps a whole lot. And now you're telling people you can't take it. This is cruel and unusual punishment in my book. And it turns out there's absolutely no reason to think that you can save it for later and gain anything by doing that. It's sort of like me telling my sons not to play tennis because you may want to play when you're my age. And so aging kind of goes like that. Every year you're older, and you can't say that. You're going to be older. Joe Mauer, if he can't turn on a fastball anymore, it ain't going to get better in 5 years if he doesn't play. So that's really the whole problem here. This is a lot of baloney, and I think if you look for reasons that this admonition was given, I think you probably conclude there are revenue streams that really generated this admonition. Myth number 5, the levodopa dose should be limited. I hear this all the time in the clinic as well. It used to be it was a lot more common until the 2 main competing drugs with Parkinson's disease went off patent, Mirapix and Requip. And so you can figure out what I'm trying to tell you. But the competing drugs, this is like the Republicans and Democrats, you know, if you don't have good things to say, they figure out some way to demonize the other guy, and that's what's going on in the world of politics. And that's how the marketing directors of pharmaceutical companies, if they have a drug that's equivalent or not as good as another drug, and you can't put anything in print that's a lie, then what you try to do is demonize the opposition. So that's how this happened as well too. But having been in practice since 1981, I can tell you that I've seen nothing in print or nothing in the clinic that would make me think that I'm doing anybody any favors by trying to restrict the amount of carbidopa, levodopa that I give people. You want to give them this so it's coming out of their ears, but it's sort of like giving insulin to a diabetic. You know, you wouldn't tell a diabetic, boy, your blood sugar is 500. I'd love to give you more than 10 units of NPH insulin, but, well, you know, we don't want to do that. We might want to save it for later, and we want to be kind of conservative, which makes about 0 sense. Myth number 6. This is something that just has been overlooked. Right? This has nothing to do with revenue streams, I don't think. Myth number 6 is carbidopa, levodopa should be taken with meals. And there was a time about 20 years ago, I remember seeing an AMA guideline. We had these guidelines in the office, American Medical Association guidelines, and it was for all kinds of drugs like ibuprofen and then carbidopa, levodopa, and it said in there, take with meals. And I still see people that get their vial of carbidopa, levodopa, and the pharmacist, thinks this is appropriate, puts a label on the vial that says take with meals. Is this a good idea? Well, I'll tell you why I think it's a distinctly bad idea. So levodopa is from a class of biologic compounds called amino acids. The reason levodopa gets into the brain is because at the blood-brain barrier there is a biologic transporter that picks up amino acids and carries those into the brain. Amino acids are important for a wide variety of things in the human body. So you need to get amino acids into the brain. And this transporter, that's how it gets in. It doesn't diffuse across, it picks up large neutral amino acids and transports those. Now it turns out that there are only so many binding sites on this transporter. So it's like a train that is picking up folks from the station, but they only have 20 seats on there and there are 15